La Fundación Cardiolili y la Universidad ICESI, cumpliendo con el propósito de promover la educación continua al más alto nivel, les da la bienvenida al 13º Congreso Internacional de Cardiología, Cardiolili 2020. En esta edición, y gracias al entusiasmo, esfuerzo y profesionalismo del Servicio de Cardiología con el apoyo de toda la institución, se hará de forma virtual, con la participación de 133 conferencistas nacionales e internacionales. Estamos seguros que el programa académico compuesto de 18 simposios en todo el área cardiovascular, que incluyen prevención, enfermería, cirugía, urgencias, cuidado intensivo y todas las subespecialidades de cardiología, cumplirán con las expectativas de todos ustedes en estos 3 días. De manera muy especial, los queremos invitar a la conferencia inaugural sobre cirugía robótica, pasado, presente y futuro, a cargo del Dr. Bob Kai desde Estados Unidos. Muchísimas gracias y bienvenidos.
Buenas noches. Desde la Fundación Cardiolili, desde el Servicio de Cardiología, Cirugía Cardiovascular, queremos darles la bienvenida al 13º Congreso Internacional de Cardiología Cardiolili 2020, que este año en su modalidad virtual nos permite llegar a muchísimos más países y, lo que es más importante, contar con muchísimos más colegas y amigos dentro de los asistentes y dentro de los conferencistas. Tenemos conferencistas
and the speakers. We have speakers from 17 countries, 137 speakers or presenters, more than 70 of them outside Colombia. So I believe it is something that the virtual system allow us to do. So we take advantage of this space in which we have call colleagues and professionals of health to share with you all their knowledge and technology of the highest level. So it is for me an honor to give the opening to this important Congress, and the initial conference will be presented.
De mesa, el doctor Diego Peña. Diego, gracias y bienvenido.
Doctor Gómez, muchas gracias por su introducción y bueno, para dar la bienvenida y la inauguración de este congreso tenemos al doctor Bob Kai, quien será nuestro conferencista en la ceremonia de apertura. Voy a pasar a inglés para hacer la presentación y que él pueda escuchar. Entonces, good evening to everyone. I have the honor to introduce Professor Bob Kai, with whom I had the privilege of working and learning from his expertise in cardiac surgery. Dr. Kai graduated with a Bachelor of Science in Biochemistry from the University of British Columbia, and he completed a medical MD at Western University, followed by general surgery residency training at the University of Calgary, and cardiac surgery residency also in Western University. He completed subsequently a fellowship in cardiac transplantation at Western University, and a second fellowship at the Leipzig Heart Center in minimally invasive and robotic cardiac surgery in Germany. He is a very well-known surgeon, and he, around the world, he performed the first North American simultaneous integrated coronary artery revascularization in 2004, the world's first aortic valve bypass using the Corres apical conduit, the world's first repair of the perforation of the right atrium using the Da Vinci robotic system in 2011, the first Canadian robotic-assisted multivessel coronary artery bypass, the world's first robotic-assisted left atrial appendage application for the atrial fibrillation, and was the first to broadcast a real-time cardiac surgical procedures to surgeons in Colombia in 2011. Dr. Kai has performed the largest series of simultaneous integrated coronary artery revascularizations in the world, and he has published more than 200 publications in the peer-reviewed literature and has served as a professor for more than 160 lectures in countries through the world. From all of these academic distinctions and his great capacity of work, Dr. Kiai is a great human being committed to education and willing to share his knowledge to those who want it. He is characterized by his leadership and excellent teamwork, and we consider him to be an example to follow as a comprehensive surgeon and physician. Dr. Kiai, please welcome to our international congress, and the audience is yours.
Well, thank you very much, Dr. Pena. It's an honor, pleasure, and a privilege for me to be able to participate in this virtual meeting. Unfortunately, the whole world is experiencing a pandemic, and it would be great to be able to visit Colombia. I've had some great memories of Colombia. I was in Cali 5 years ago at another meeting. I have great memories trying to learn salsa. So it's too bad that I cannot experience the rich culture and the amazing, you can say, collegiality in person, but I'm glad that I'm able to participate in this virtual meeting. It was an honor to have you with us, Dr. Pena, the period of time you were with us, and I'm extremely proud of being able to kind of participate in this meeting that you have organized. I'm just going to start by my title of my talk is, as was asked for me to talk about robotic surgery, which is one of my passions, past, present, and future of robotic surgery. And I'm going to concentrate not only specifically on cardiac surgery, although robotic surgery was created because of cardiac surgery, but I'm going to provide a very general presentation of overall what has occurred in terms of this particular field. This is my following disclosure. I'm a consultant with the following companies. So if we go back historically, Aristotle was the first individual that bring the concept of automation. 4th century BC, there's a quote from him stating that if every instrument could accomplish its own work, obeying or anticipating the will of others, if the shuttle could weave and the pick touch the ire without the hand to guide them, the chief workman would not need servants. And this is the idea of overall automation, and computerization was basically introduced. It was not till 1350 where the very first automated rooster became available in the cathedral in Strasbourg, France. And then in 1920, the term robot first appeared from a textbook by Karel Čapek, who's a Czech author. And in basically Czech, robota means basically serf, which is servant. And this book was a book on Rossum's Universal Robots, which was a play where basically labor was performed by machines and free to enjoy basically life of leisure. In terms of what occurred afterwards, 1942, Isaac Asimov basically published a book on robotics in Runaround, and then in this particular book, he came out with 3 laws that apply to robotics. The first law was robots may not injure a human being or allow it to come to harm. Second law was robot must obey the orders given by human beings, except if it conflicts with the first law. And the third law was robots must protect its own existence as long as does not conflict with the first and second laws. In 1951, Raymond Getz produced the first teleoperated articulated arm for the Atomic Energy Commission. And then 1954, George Devil created the first programmable robot And it was in 1962 when robots were introduced to the automobile manufacturing, where General Motors installed robots into this production. This continued on, and in 1974, NASA basically came up with robotic arms. 1980, in Japan, Fujitsu produced the very first totally automated factory. 1989, Yulin Wang was the founder of Computer Motion, which was the very first robotic company. And then at the same time, came up with 1993, which was ESOP, which was first voice-controlled robotic kind of arm that basically controlled the camera and was cleared by FDA in 1996. And that's about a time when we were introduced to robotic surgery in basically Canada. 1998, the three-arm robotic arm, the Zeus robotic microsurgical system, was introduced, again by Computer Motion. And subsequent to that, about the same time, Friedrich Moll and Robert Young and John Freund formed Intuitive Surgical. Now, the interesting story about Intuitive Surgical was that this was a project that was by the United States National Defense and NASA, and the purpose of it was to provide the best surgical treatment to people in the outer space or in the battlefield. That was a main project of what basically created the Intuitive Surgical system. Financially, this was very difficult at that time. This was, again, in the early 90s when they were working on this. So hence, they decided to sell it to private enterprise, and hence that's where Intuitive Surgical was created. So then, why is surgical robotics necessary? Well, as we know, in the last quarter of the 20th century, and especially during the last decade, there's been a paradigm shift in the method by which surgery is being performed. The invasiveness of a lot of procedures, specifically in a lot of other disciplines of surgery, was dramatically reduced with superior outcomes. This resulted in improved survival, fewer complications, and quicker return to functional health and productive life, which is what everybody is seeking these days. Therefore, the surgical procedures that at that time existed were primarily all excisional in nature and not reconstructive or microsurgical, which is what cardiac surgery really is. Hence, it led to the unrealistic expectation that other surgical procedures, such as microvascular reconstructive cardiac surgery, could undergo less invasive surgeries. This was not possible due to the limitation that existed with the conventional endoscopic instruments. The conventional endoscopic instruments were all like chopsticks, and hence they didn't have all the degrees of freedom that required to do a very highly, you can say, enhanced procedures such as cardiac surgery. Therefore, when in the 80s, there was a significant enthusiasm and momentum after the first laparoscopic cholecystectomy was performed, it became obvious to surgeons that they could actually perform a procedure without actually directly touching the tissue that they had to operate on. So endoscopic surgical techniques became adopted by different surgical disciplines because of the decrease that was with the morbidity and the shorter recovery times. Unfortunately, this was not possible in cardiac surgery due to the limitation that existed with the minimally invasive surgery. And hence, computer-assisted surgery or robotic surgery was introduced to try to basically overcome these limitations and provide all the degrees of freedom, or what we call the digital interface between the surgeon's hands and the instruments. This enhanced surgical technical ability and allowed endoscopic microsurgery to be performed. The human hand can be exactly copied by all the degrees of freedom that we have with the 7 degrees of freedom with our fingers, and allows us to perform all the procedures that we're able to do. At that time, only 2 companies existed: Computer Motion, that came up with the automated endoscopic positioner, and then Zeus, which was a 3-arm system, and of course, Intuitive Surgical with the very first generation Da Vinci robotic system. We started performing endoscopic harvesting of the left internal thoracic artery using this automated positioner that hold the scope, and we were able to control the scope with voice activation. This is the system that existed with mount on the edge of the table, and was able to hold the camera and followed the commands of the surgeon. This is right in the operating room performing a left internal thoracic artery harvesting. The 3-arm system was then introduced where the 2 arms were controlled by joysticks, and the camera arm, which is basically labeled as A, was again also controlled by the voice of the surgeon. And this is in the operating, as you can see, where the 3 arms are holding the camera, 1 arm's holding the camera, the other 2 arms are being operated from the system. The only disadvantage of this particular system did not have the 3-dimensional binocular view, and hence was a disadvantage, and hence you had to wear specific camera at that time, specific magnifying glasses to get the 3D vision. This is the very first Da Vinci first generation, which we acquired in 2003, and we started utilizing this system back at my institution in London. This system definitely has now undergone significant revisions. So if I can go back and basically bring people's attention to the presidential address that was addressed in 2000 at the American Association of Thoracic Surgery by Dr. Cosgrove, which was innovation is imperative. In his talk, he mentioned that we must think anew and act anew in clinical practice, education, research, and healthcare delivery. At no time in human history has the potential been greater for translating biological knowledge and technical capabilities into powerful tools for preventing and treating disease. This was an extremely powerful presidential address, delivered the fact that we can translate the knowledge we have into basically actually providing care to our patients. So what happened after that? Well, surgical robots were specifically built at that time for cardiac surgery to enhance microsurgery. Unfortunately, due to, again, limitation of other devices to complement robotic surgery, cardiac surgical procedures were very minimally utilized with the robot, and hence there were some very early adopters, but not enough to sustain the necessary volume required for the company to be able to provide the needs in terms of the revenue. Hence, as you can see here, when the robot was introduced, which is a typical technological dissociation curve of any new technology, there was a very, very sharp rise in basically utilization of the robot. But then, as people discovered that they don't have other complementing technical abilities to perform further robotic procedures, there was a significant drop. And this is where was critical, because if this continued this slope, a bankruptcy could have resulted, and therefore the company would have not done well. But interestingly, at that stage, other disciplines of surgery started to utilize the robot, specifically urology, and hence you had a significant increased utilization of the robot, and hence the curve increased. So cardiac surgery was the very first disciplines of surgery started utilizing the robot, then urology, specifically with the prostatectomies, and then thoracic surgery, then general surgery, then gynecology. This is again in terms of the previous utilization of the robot. When we started using the cardiac application for the robot was primarily for coronary bypass surgery, single vessel bypass, then we increased that to multi-vessel bypass, and then of course hybrid revascularization. Furthermore, this procedure can be utilized for mitral and tricuspid valve surgery, atrial septal defect closures, left atrial appendage ligation, and of course, other endoscopic procedures which robotic assistance can make it easier. So why was there not an early adoption? Well, because robotics includes risk taking. Taking a risk means daring to try new approaches or ideas or goals with no predictable control over either positive or negative results, nor the consequences that's unknown. Hence, because of that, people were apprehensive to really adopt this technology. So taking a risk to avoid a bigger risk. For example, if we didn't have risk takers in cardiac surgery would never evolve. It's because of these exemplary risk takers, such as such individuals, that allowed us to be able to see where we are by these big pillars in cardiac surgery that enabled us to basically achieve where cardiac surgery is presently. Hence, taking a risk is important. The risk in robotics can result in different forms. risk of failure, risk of injury or death, which can affect yourself, the family of the patients, colleagues, and the patients itself, of course. Risk of criticism from colleagues, from the public, from regulatory bodies, ethicists, whether it's ethical or not. And of course, the risk of feeling embarrassed because you're using a new technology that was not yet fully approved. So again, the risk can also show the loss of credibility, expenditure of resources, time wasted, potentially bodily injury, and again, criticism. Subjecting patients to unproven technology, as mentioned, or withholding proven operation with known excellent results. So it's critical to also inform the patient of all possible complications, incomplete patient understanding of the risk, and incomplete comparison to proven methods, specifically making sure that the patient fully understand what the technology involves. The ethical concerns is, again, withholding new technology, such as basically replacing a valve when the valve is repairable, or not allowing a patient to get access to minimally invasive surgery when the patient is a good candidate for minimally invasive surgery, or using saphenous veins predominantly in younger patients, all right? This is ethically not correct. Or, for example, not utilizing all arterial grafts in a CABG versus doing PCI and stents, again, on a young patient. These are all, again, very ethical concerns. So the robotic success pathway is you calculate the risk-taking, you basically look at the scientific curiosity, then you do the applicative ability, you do it in an organized approach, then you prioritize what needs to be done in that particular order. In addition, you have a clinical goal and you want to make sure that benefits and provides safety for the patients. You make sure you've got adequate collaboration, teamwork with different disciplines. And you have to here be open-minded, learn new skills, and you have to basically don't only stick to your training or discipline. This is where it's critical to be able to basically have an open mind and be able to see new ways of learning new techniques. So the risk of surgical robotics. Well, ideal risk, for example, inadequate resources, which was existed specifically when robotics was introduced. We didn't have all the technological, you can say, compatibilities to be able to allow cardiac surgical procedure to be performed. Intellectual property, criticism, again, embarrassment, wasted energy, and wasted time by utilizing technology that may not get anywhere. A lot of the cardiac surgeons initially felt that way because they couldn't basically complete the tasks that they basically started. In terms of the finances, well, we're gone through an industrial development, which basically has got industrial, personal litigation, the resources, and the personal investment that people put into it. All is very critical. The clinical risks, of course, of surgical robotics, if you have a device related to patient injury, a procedure that basically alters and causes injury again, further operating prolonged times, for example, increased cross-clamp time, increased OR times, all were things that were associated with the first adoption of cardiac surgical procedure with robotics. Patient not informed completely of what they're going to be exposed to. And of course, you need proper institutional review and regulatory scrutiny by the IRB and, of course, of your health authority regulatory bodies, such as the FDA. Your personal reputation is at risk, specifically for litigation. And again, there's always all these detractors, such as ethics, jealousy from colleagues, basically the resources spent, that basically further detracts individuals to concentrate and hence resulted in basically not full adoption of this technology. How do you manage these risks that are associated with robotics? Well, I think it's critical to do a procedure when it's indicated. So patient selection for robotic procedures is extremely important. Not every patient is meant to go robotic procedures. You have to make sure that you basically select patients to reduce the risks of the operation. So you develop basic protocols and you follow the protocols. Collecting data is very important. You got to be meticulous in collecting the data, analyzing, self-evaluating, and do mid-course correction if necessary. And you got to make sure you've got full approval by your institutional review board and your local health regulatory body. As they say, without data, you're just another person with an opinion. So it's critical to have proper data to make sure that you have enough arguments, enough reason to compel that this technology basically is actually effective. Other management risks that are associated with robotics is you must inform the patient in terms of making sure the patient fully understands what they're undergoing, educate the team and colleagues, make sure the team is very fully trained, never utilize multiple new technologies. When you introduce robotics, make sure you just robotics, not under, for example, in cardiac surgery, if you're introducing robotics and you're not familiar with the endoaortic balloon, you can't introduce two technologies at the same time. You got to make sure that the team becomes familiar with one technology before another technology is introduced. And of course, you got to make sure you've got full institutional support, specifically of your administration, and you got to be insightful and honest with yourself. Make sure that you're doing exact good procedure as you would have done it conventionally. So in terms of the Da Vinci system, the Da Vinci system has gone significant evolution. We started with the very first generation, then the S and the SI system, and then most recently the XI system, which is basically shown here, which is completely been evolved into much more user-friendly systems. But again, this has got significant further improvement that needs to occur, and we have further companies that are basically in evolution right now to come up with other particular systems that would make this again more suitable for the operating theaters. This is the Da Vinci XI, which is primarily used these days. I'm fortunate that my institution here in Sacramento at UC Davis, we have access to the Da Vinci SP, which is a single port. These actually would work very well in cardiac procedures. However, they're not yet fully approved for FDA. It has to be done basically under another kind of an umbrella. But again, this would be another way by which, again, you can again do some cardiac surgical procedures using the single port method. So presently, all these disciplines of surgery are performing robotic assisted procedures. Cardiac surgery, ENT, general surgery, gynecology, orthopedics, thoracic surgery, and urology, and the primary utilization being in urology and gynecology, and specifically general surgery and colorectal surgeries these days. So robotic cardiac surgery is a team approach. You cannot do this with just one individual. You have to have cooperation, coordination from all different disciplines of surgery, medicine, such as anesthesiology, cardiology, radiology, perfusion, nursing, and of course, biomedical engineering. And same thing will apply in the other disciplines of surgery, where it's critical to have a team approach because robotic surgery is associated with team rather than just one individual. And specifically related to heart, this is definitely a heart team approach where the patient and the family are in the center, and you've got all the different specialists basically contributing together, collaborating, delivering that care. I'll provide you this case report that basically of a patient that, again, at the days where robotics was primarily utilized for some procedures that was indicated, sometimes it's always good to think outside the box and use robotics and minimize the risk in the patient. This was an 89-year-old female patient that presented with tachybrady syndrome, had abnormal heart rate, was on chronic steroids, had very severe rheumatoid arthritis. So patient underwent basically percutaneous insertion of a transvenous permanent pacemaker. Post-insertion pacemaker was not capturing. They did a chest X-ray and noticed that the pacer lead was extrapericardial. So this is what we saw when we put the scope in the patient. As you can see, the leads are, the lead is through the right atrium. And to perform this procedure through a thoracotomy on an 89-year-old or a sternotomy would be very invasive. If you want to use regular surgical instruments, would be extremely also invasive and potentially result in significant trauma to the heart because you're using a beating heart. So we brought the robot in and we said, why don't we go ahead and basically robotically put a purse string at the site of perforation. And while we do that, we would then basically pull the pacer lead out. As you can see, this procedure would not be possible without having all the degrees of freedom to be able to put the sutures without having that, you can say, endo wrist action that the robot gives you. Without that endo wrist action and suturing these on a beating heart with regular endoscopic instruments will result in significant potential tear of the atrium in an 89-year-old who's basically steroid dependent. So as you can see, using this, we used Gore-Tex sutures. We were able to basically bring it together. As you can see, we put the first string, that's pulled, and the suture is tied. Again, this is a team approach because the suture was delivered to me by the bedside surgeon while the consult surgeon basically tied it. And again, we were able to very kind of within like 10 minutes, basically close that hole. Again, it can be very difficult to do it without the 7 degree of freedom of the robot. Again, the bedside surgeon comes and cuts that, and there it is, it's done. This patient was able to leave the hospital second post-operative day. So as you can see, the trend in robotics is increasing worldwide. This is in the US hospitals, and the numbers increasing from 2015 to 2019. Similar thing is seen in Japan. The Japanese have really adopted robotics. 2019, the number has really gone up. And this is some procedures being performed in Europe, such as Germany, since 2008. What's the future of robotics? Well, despite all the attendant risks that I mentioned, the pathway of innovation is carpeted by leaves of curiosity. Us being clinicians, scientists, we're curious and we want to always perform procedures in a much more satisfactory way. And therefore, the fruits of hard work and frustration is very challenging. But however, because we are in, you can say, seek of providing better care, the future, I think, is looking very bright. Technological innovation, whether applied or basic, remains the insular pathway to new therapy. The surgeon who sees this challenging, basically, helm become the captains of innovation and secure surgery's future. Those who avoid risks abrogate the patient's fate to those who can systemically manage risks incumbent in this progress. Seemingly, the major risks today have become the costs that's associated with deploying new technology for the care of patients. Robotics of the future is that this innovative technology applied basically allows a surgeon to basically advance in the right direction. For example, if you look at the US healthcare expenditure in 2019, it's reached $3.6 trillion. So this technological advance, such as robotics or further things that I'm going to just introduce in terms of automation, is going to increase the delivery of costs. So this means equivalent to $11,500 per person. Looking at the life expectancy continue to increase in basically patients, specifically in basically countries that basically have access to this technology. So the balance between utilization of this technology is the cost associated with it. So surgeons who enjoyed and relied on gold standard methodology have realized that patients demand improved operations or prefer no operation at all these days. Also, by us observing the significant good results of catheter-based revascularization, cardiac surgeons have begun to modify operation towards better ones, hoping that to gain the benefits of rapid recovery, pain reduction, improvement in cosmesis and neuroprotection, and specifically the longevity of the operation. We should not compromise the longevity of the operation by the introduction of these new technologies. So surgeons are beginning to develop or test new devices and techniques after having seen improvement in conventional outcomes. And hence, this is where I think the application of robotics and artificial intelligence it is, which is a dream of what must be done and ways to do by co-opting the technological advances into devices and new methods. So this is where I think that the next step of the future is robotics and automation. You have fully manual procedures being performed, and then you have automation where you've got the human touch with automation, and then eventually you're able to basically make it fully automated, especially if the procedure is a repetitive procedure. And that's what's going to be occurring with the field of robotic surgery. So if you look at automation and artificial intelligence, the human is able to train and empower the machines, which is the artificial intelligence, which utilizes data, analytics, insights into decision making. This can be conversational, interaction with the user. It's cognitive because it allows basically the unconstructive data to be analyzed. And of course, when you take the artificial intelligence and combine it with robotics, you can have a repetitive rule basically of a high volume activity. For example, 6 out of 10 occupations, around 30% of the tasks can be automated. What that will result is decrease in burden of performing the procedure and increased productivity if you can automate things that are repetitive. So this is an interesting concept that I think is becoming more now apparent, artificial intelligence and machine learning. If you look at the number of articles published in surgical artificial intelligence and machine learning has significantly increased over the last 5 years. Now, artificial intelligence and machine learning follows the same curve as any type of new technological advanced technological trigger, which you have a peak and then of course a trough that drops. Now, artificial intelligence is when any aspect of learning is introduced to a machine and the machine is able to basically learn that. Now, a subcategory of artificial intelligence, which is shown here as machine learning, is when you are able to basically, from data that's accumulated, further teach the computer to basically learn automatically. Then another layer of that machine learning is the deep learning that the machine, again, is able to recognize patterns independently and make predictions after analyzing large quantities of information. So all these put together with robotics, you'd be able to have basically innovative technology that can perform procedures accurately, specifically is the repetitive type of a procedure. So again, as I mentioned, this is the curve where basically becomes quite the peak of inflated expectation. The early adopters here grab it, but we have to make sure that this continues in the right pattern by making sure that the proper research and development goes into this particular type of field to allow us to have this. For example, over the last, is predicted in the next potential 5 years, over $36 billion of healthcare is going to be given to basically artificial intelligence. And by 2026, $278 billion of digital healthcare basically investment will be made, which will be 36% into basic application of apps and 26% in telehealth, which has become more apparent in the era of COVID. So this is when artificial intelligence and surgery can be basically combined in delivering the care of a patient that basically will benefit and provide more accurate and more repetition type of a procedure. For example, if you look at, the procedure that thus far exists, there is a particular company called Hip Expert, where you've got a personalized planning and navigation for total hip arthroplasty, where it uses a CT scan. Based on the CT scan, you go ahead, provide the proper positioning, sizing of the prosthesis to make sure the leg length doesn't get affected, make sure that the pelvic tilt is not offset, and everything is done by the artificial intelligence in combined providing information to the robot that delivers that type of a care. You have smart tissue anastomotic robot, or a vision-guided robotic system for laparoscopic suturing, and basically provide it and basically will suture better than expert surgeons, specifically if it's done as a repetition. In addition, we know that now remote patient monitoring to automate postoperative care. These things are all coming and it will allow us to provide better care. For example, virtual hospitals, home cares, basically can have remote monitoring by several companies such as Philips, electronic transition, and ambulatory care after surgery such as vascular or cardiac operations. In addition, also, the artificial intelligence or the computer can be a diagnostician. For example, it can be programs made where it can be a triage and notification of software. Most recently, there was an FDA-approved algorithm that is able to detect cervical spine fractures, intracranial hemorrhage, pulmonary embolism, based on basically the x-rays that can be analyzed by these computers. As you know, the ECG, which is the electrocardiogram, we already had that occurring in it, where it would basically be able to read the electrocardiogram, say whether you're having an MI, not having an MI, or what kind of basically diagnosis you have. Now, a lot of times that was not accurate, but it's getting better and better and better. Well, similar type of technology is now being introduced by looking at x-rays, by being able to see CT scans and detect things that potentially can be missed by basically the individuals reading the x-rays. Here you've got an AI-powered platform for improved pathological diagnosis, such as liver histopathologies. You've got now software to be able to diagnose COVID basically from chest x-rays. So artificial intelligence that can look at specific aspect of a chest x-ray, say this patient is suspicious for COVID. So all these are, you can say, the future of computerization that will enable us to deliver the care that we can to patients. In addition, there can be a hybrid model of automation where you take an automation in several different aspects of it and put it together. For example, you've got traditional workforce in combination with the digital workforce working together in providing basically the care for the patient. In terms of delivering the care, some aspects of it can be done traditionally, but then when it comes to automation, for example, putting sutures in for a mitral valve annuloplasty, they're always most of the time the same. You can automate that, allow that basically artificial intelligence system working with the robot deliver that. So future robotic surgery, which is basically as expected an innovation in robotic surgery 2020, 2030, is technologies and players and markets that work with surgical robots, robotic catheters, endoscopic navigation system, robotic positioning of surgical tools, robotic systems for intraoperative camera manipulation, artificial intelligence for robotic surgery, and haptic feedback mechanisms. All these are what is going to basically allow robotic surgery to enter a new era in delivering the care to our patients. This, for example, is a robotic surgical suite. As you can see, you've got several robots with different instruments where the patient can be wheeled in, and these can move around, controlled by, of course, the surgeon, basically sitting at a console, delivering the care it is. So again, this particular field, again, is at its infancy, and the significant amount of potential possibilities of it combining with artificial intelligence, delivering it, is what the future of basic computerized surgery is all about. With the rise of basically robots can be seen in surgical environment of COVID. As we know, COVID-19 has completely changed the way we practice in different fields, where we basically now do a lot of patient assessment without seeing the patient. With a lot of it's done video, you can say conference, but at the same time, robotics allows us to basically deliver some care without the contact with the patient. So you reduce the contact between the healthcare provider and thus less need for this PPEs, as they say, and also allow basically maximum capacity of delivery and not reduction of a lot of the procedures that has occurred worldwide. So with basically what we all experiencing, well, life gives you 100 reasons to break down and cry. Show life that you have 1,000 reasons to smile and laugh. And we should all stay strong, because I think the technologies that is coming, stay forth for us, will allow us to deliver that. It always seems impossible until it's done. In his presidential address, Dr. Guyton in 2004 stated the following: cardiac surgery will not disappear, but it will change. We must consider innovation, because innovation equals survival. Surgeons who do not innovate will not survive, because referrals will shift to those state-of-the-art practitioners who are seen as innovators. We must remain patient-centered. And I say that again, patient-centered is the #1 focus we need to have, and evaluate and focus on new technologies or procedures that offer the most patient benefit. Predicting the future is what Dr. Starzl mentioned. What was inconceivable yesterday and barely achievable today will become a commonplace tomorrow. Thank you very much. I appreciate your attention, and it has been a privilege for me to be able to participate in this virtual meeting. Thank you again.
Doctor, thank you very much. It was an excellent conference. We want to thank to the more than 800 participants for this opening conference. We had people from Peru, Bolivia, Argentina, Ecuador, Mexico. They say hello from Sweden and many other countries. Diego, si estás para que me ayudes con las preguntas.
Thank you very much for your lecture, Dr. Kiai. We have a chat and that the participant has posed some questions. If you want, we can go ahead with that. The first one is, how many cardiac procedures per year must need to be done to consider this therapy cost effective?
Well, I don't think that there's any specific number that makes the procedure to be cost effective. I think the purpose that results in the cost effectiveness of these procedures is the reduction in length of stay in the hospital and the reduction in potential need for intensive care unit. At my institution, before coming to Sacramento, we adopted an ultra fast track recovery post robotic surgery where patients avoided going to the intensive care unit and they went to the recovery unit and they were able to then be discharged potentially second or third day postoperatively. So I think that number, I think the number is more critical for the team to become more comfortable with the procedure. I think that you need to perform at least a minimum of between 20 to 30 procedures per year to allow the system for your team to become familiar with it and you yourself to be able to perform the procedure safely. So I would say that to answer your question, I think that you definitely need to perform minimum between 25 to 30 procedures a year to make it cost effective and also to become safe.
Okay, there is another one. They say, hi, Dr. Kiai. First of all, thank you for your lecture. My question is the following. Do you see this field of cardiac surgery will be taken over from interventional cardiologists in a not so distant future? Or do you believe both fields will be operating together?
Well, our intervention cardiology colleagues, or even also the interventional radiologists, have already adopted and started to utilize robotics for a lot of the transcatheter delivery of their procedures. Because again, instead of them utilizing their hands, they can use a robot to be able to manipulate the catheter. So I think that the field of robotics is also helping our, you can say, intervention colleagues. But eventually, both of those fields will definitely go in parallel. There's no doubt about that. We will work basically together in terms of delivery of, you can say, a hybrid type of procedures, whether it's for revascularization or whether it's for valvular procedures or even you can say arrhythmia treatment, to be able to deliver that combination with robotic assisted transcatheter procedures and robotic assisted surgical procedures.
Okay, thank you. A third question is, which cardiac procedure is the easier or most appropriate to start a successful robotic surgery program?
So in cardiac surgery, probably the procedure to start with would be not an intracardiac procedure, such as valvular procedures, because it requires the utilization of cardiopulmonary bypass. So I would first start by performing revascularization, specifically harvesting the internal thoracic arteries, either the right or the left internal thoracic artery. That's what we would be best to start with, to become comfortable with that. And then once that's done and you've basically achieved your comfort zone with the robot and comfort zone with the team working together, then you can further expand that to intracardiac procedures such as mitral valve surgery, such as different intracardiac procedures, removal of myxomas or ASDs, such procedures.
Okay, there is another one. How important is to have any experience in minimally invasive cardiac surgery before starting to robotic surgery?
I think that having exposure to minimally invasive cardiac surgery is not a must. I think definitely would be helpful because you're familiar with the anatomy seen minimally invasively, because it's different than looking at it through a sternotomy. But however, because the robot gives you all the degrees of freedom, I think that individuals who want to embark on basically utilization of the robot, I think on simple procedures such as, for example, endoscopic harvesting of the internal thoracic arteries is much easier doing with a robot than done minimally invasively with the endoscope. But for intracardiac procedures, I think that would be good for an individual to have exposure to minimally invasive procedure, to know exactly what is the steps involved with it, because the steps involved in minimally invasive intracardiac procedures are very similar to the one with the robot. What the robot does is increase enhancement of being able to provide the extra dexterity you need to perform the procedure. So to answer the questions, for intracardiac procedures, definitely would be beneficial to have previous exposure to minimally invasive surgery.
Okay, right now, Dr. Kiai, we have 800 participants connected. There is people from Brazil joining the discussion, and there is also more people from Argentina and from Salvador also. So we have connected already around 7 countries in Latin America and others in Europe. So there is another question. When do you think we'll be using exclusive AI and robotics in cardiac surgery?
Well, I mean, to be able to apply artificial intelligence right now to cardiac surgery is, again, in a very early stages. But I think that for some simple procedures such as, for example, I mean, down the road for diagnosis, I think would be first to see whether it's basically effective or not. And then that can be further expanded into potentially utilization of automation. So the future is whether we can take some procedures that we think that are not going to change based on patient's anatomy and see whether can we apply this to utilization with computer assisted and automation. So for example, if you can basically, as I mentioned, the annuloplasty sutures have basically the surgeon basically expose the valve and then basically have the automated system be able to put the sutures in exactly the way you want it by showing it to go at depth you want it to go and travel a certain distance. If you can put those programs into a particular computer, then that can be achieved. So I think those are all potential milestones that can be reached for us to get to a point in life where we can use the human interaction with artificial intelligence to deliver the care.
Okay, there is a last question from Spain. They ask, what are the troubles that you have more often seen in cardiac robotic surgery and how you have overcome them?
What are some of the challenges with cardiac surgery? Is that what it was for robotic cardiac surgery?
Like troubles of yeah.
Pitfalls.
The pitfalls.
I think that number one is patient selection. If you select the wrong patient, you're going to have trouble with it. So it's very critical to be very diligent and very picky with, specifically when you're starting, to pick the right patients to do the procedure and the patient that definitely are the correct patient to have the procedure. If you do that, then you avoid it. But the major problems are, for example, the difficulty arises when you injure a vessel and the blood vessel, for example, in the ITA harvesting, during the dissection of the ITA, suddenly a branch of the ITA tears and you have bleeding. And with the robot, it's a 10-time magnification, so the bleeding is significant. It's way more than it is. So I think that when that happens, you just have to spool, apply pressure, see whether that can stop, and then see what can you do to basically rectify the problem. And if you can't, basically convert at a time to make sure that you don't cause harm to the patient. So, but depending on what type of procedure you do and what type of a difficulty you confront, I think in revascularization would be to make sure that everything you can in robotics, you can't speed the procedure. You can't do a fast robotic procedure. You have to basically concentrate because an error will result potentially in conversion. Hopefully that answers the question. And of course, for intracardiac procedures, the biggest thing is to make sure that the patient you're doing are not have problems with high pulmonary pressures, does not have aortic insufficiency if you're doing a mitral valve procedure. So there are different, basically, you can say categories.
Air embolism is a problem in robotics.
There is a last question, Dr. Kiai, about air embolization in robotic surgery. Do you think this is a problem that is less than in robotic than in the open surgery? I mean, air embolization.
Not particularly. Air embolization, I mean, you have to be careful in being able to de-air if you do an intracardiac procedure, just like performing it without a robot, you have to make sure that you de-air properly. So utilization of CO2 is extremely effective, especially if you're doing a robotic with a smaller incision. Then the CO2 really, it's critical to insufflate the CO2 into the thoracic cavity and make sure that the CO2 helps with the de-airing procedure. But again, you have to be patient. And if you have intracardiac air, you have to make sure that you fully remove the air before you basically take the patient off pump, because that will definitely cause problems with potential air embolization. But I don't think it's any more with robot than it is performed using kind of a minimally invasive endoscopic methods.
Great. So we will take just one more question, Dr. Kiai. Where are the most frequent procedures performed with robotic surgery?
Presently, the most frequent procedure performed by robotic surgery are mitral valve repairs. Mitral valve repairs are the most utilized procedures because presently the technology, we have everything we need to be able to perform a robotic assisted mitral valve surgery. We've got a great left atrial retractor, and we've got basically all the technological other, you can say, instrumentation that is needed for the robot to be used. So the mitral valve surgery is probably the most utilized now procedure in robotic surgery.
Okay, Dr. Kiai, so this is all of the questions, and we want to thank you once again for your lecture and for your participation in our meeting. We are so proud of having you here, and we much appreciate your time, and we are looking forward to having you here in our institution next year if the world pandemic allowed us. But for sure, this has been delivered for already 800 people, more than 800 people around the world. So probably it's an advantage of this situation. So thank you very much for being with us.
It's a pleasure and honor. Thank you very much for the opportunity.
Doctor, they say hello from United States, Spain, and also Nicaragua. They all say hello to you.
Wonderful. Say hello back. It's a pleasure and honor for them to be in the audience. Thank you.
Thanks again. Un mensaje para todos aquellos que tuvieron dificultades en la traducción a español. Vamos a enviarles a su correo electrónico el instructivo de cómo se debe hacer el botón que deben hundir para llegar a la traducción a español o inglés para las siguientes actividades. Esta conferencia queda grabada. Ustedes tendrán acceso a esta conferencia una vez termine el Congreso y les estaremos enviando el link para el acceso a esta actividad. Le agradecemos al Dr. Kiai. Welcome to Cali in the future. Welcome to the Salsa Country. Y agradecerle a los casi 900 asistentes de diferentes partes del país, del continente y de otras zonas geográficas. Muchísimas gracias. Nos vemos mañana en el inicio de las actividades académicas, desde las 8 de la mañana con los simposios patrocinados y a las 9 de la mañana con las actividades académicas. Muchísimas gracias. Thanks again. Goodbye. Thank you, doctor.
Bye.
Goodbye.
Thank you.
Bye, Dr. Kiai.